I'm Alan Cohen. I'm the GP working at Broadmoor, and I was going to talk about risk reduction, and particularly about cardiovascular risk reduction and what we've done at Broadmoor. I used to be a GP in Mitcham. I don't know whether any of you know Mitcham at all. Yeah? Well, I have to say that the population of Mitcham is actually no different to the population where I work now at Broadmoor. They seem completely similar, certainly so far as personality disorder is concerned. You don't live in Mitcham, any of you, do you? No. And the relevant bit, the reason why this is important, is because of the comparative risk of death that Steve was talking about, that Julia was talking about. And the risk of death in people with schizophrenia from long-term conditions is greater than the risk of death from either suicide or accident. You can see that people die from stroke, from COPD, from cardiovascular disease and diabetes much more commonly than if they didn't have schizophrenia. The combination of diabetes and schizophrenia is a lethal combination, and that's why we need to be doing something about it. Managing the risk of premature death, you've heard so much about it already. There's a process that one can go through. What was interesting was that Paul and Steve were talking about a public health approach. And the public health approach is about identifying the at-risk population, assess their risk, use the NICE guidelines to target interventions at those at greatest risk, evaluate the care, and then compare to national benchmarks. And that's a very straightforward process that public health doctors are very familiar with. What was interesting is that we didn't have the national benchmarks. We didn't know when we started looking at cardiovascular risk what was the risk of cardiovascular death in high secure hospitals. And I think Paul was very modest in his role in this. The commissioners came up with the money to allow the 3 high secure hospitals to commission the research that Julia Hippisley-Cox presented this morning. So this was the first time that the results of that paper were made clear, were presented, and that paper was a result of a sequin incentive from the 3 high secure hospitals working together. West London just managed the paperwork, but it was the 3 high secure hospitals that did the work. And at Broadmoor Hospital, that's our age distribution of men only. You can see that it does work, brilliant. A predominantly young population, but some patients moving up into the 70s, but not that many. And age is one of the features that affects cardiovascular risk. And as Julia said, it's defined as a percentage chance of suffering a cardiac event, MI or CVA, in the next 10 years. And it's expressed as a percentage. And the national figures are anything above a 20% risk is considered a high-risk patient for which resources should be targeted. And again, the factors influencing cardiovascular risk are the things that you might be familiar with in diabetes, chronic renal failure, a high systolic blood pressure, a high BMI, raised lipids are all things that influence the risk of suffering a heart attack or a stroke, as does atrial fibrillation. Rheumatoid arthritis is quite interesting. Those of you who have clinical contact, do any of you have patients with schizophrenia and rheumatoid arthritis? The textbooks say that there's an inverse relationship, that if you have schizophrenia, you don't get rheumatoid arthritis. So the absence of rheumatoid, so that there are very few patients, so far as I'm aware, in any of the high secure environments with active rheumatoid. But rheumatoid arthritis on its own is a risk factor for cardiovascular disease. Smoking is an enormously strong and powerful risk factor. And you'll be hearing this afternoon from Louise Restrick, who is the head of the respiratory team in London, and is an extraordinary woman who speaks very passionately about the effect of smoking on people with severe mental illness. That is particularly what although she's a respiratory physician from the Whittington in London, North London, she's particularly interested in smoking and people with severe mental illness and cannabis. She has some really frightening slides of the effect of smoking and cannabis smoking in people with severe mental illness. Race, genetics, family history, and deprivation and sex are all other indicators. Now, what's interesting, that lot we can't do anything about. We can't influence those as clinicians, but we can influence some of those. So, using the score, using the cardiovascular risk score at Broadmoor, we've been able to reduce the risk. Patients with high risk of cardiovascular disease, above 20%, was 7% when we started doing this in 2010. And we reduced that down to 2.1% over the space of 3 years for patients who have been present in Broadmoor for those 3 years. We've made a very significant change by a number of different interventions. And those are the things that I'm going to talk about next. And that figure is very close to the 1.7% that Julie described for the community target. So if we're talking about parity of esteem and equivalent outcomes, we believe at Broadmoor that we've been able to reduce the cardiovascular risk to a level that one would expect to find in the community. The way we've done that is we've looked at several types of interventions. We've looked at smoking, we've looked at targeted interventions, and some innovations. And looking first at smoking, as you know, smoking was stopped at Broadmoor in 2008, as it was at Ashworth and Rampton. And that has made an enormous difference. Those of you who are working in medium and low secure units, Steve Shrub began to talk about the consequences of a no smoking policy and how it might be introduced. As a GP, I work both at Broadmoor and at our medium secure unit in Ealing, and the difference in morbidity and mortality in the two groups of patients with the same mental health problems, the same very similar risk problems, but one group smoking and one group not, is extraordinary. We haven't had a patient admitted from Broadmoor with a chest infection for over 4 years. We haven't had, I was looking at the number of chest infections that I've treated with antibiotics over 3 years, virtually none. Whereas at Ealing, where patients smoke, the number of admissions for bronchopneumonia, chest infections, and the complications of smoking are enormously high. Even the incidence of diabetes is higher at Ealing than it is at Broadmoor. So there are lots of reasons to think about a smoking cessation ban. Over 75% of patients smoked at Broadmoor, and I suspect you know better than I do some of the pharmacokinetics about why people with severe mental illness smoke, and the idea that it blocks the unpleasant hallucinations and delusions that people with schizophrenia get. The nicotine does that. Although I wasn't in the hospital at the time, I'm told there's very careful planning around smoking cessation, about how it was introduced. There was fear that the nicotine, that stopping smoking would allow drug levels of antipsychotic medication to fall with a risk of increased aggression, so that every patient had their own individual care plan on the smoking day. And in fact, what they found was that there was no aggression, no extra aggression, no decompensation, no exacerbation of psychotic symptoms, that with careful planning, it was very safely undertaken. And the impact on physical health I've talked about already was very significant. We looked at some targeted interventions. We used a quality and outcome framework. Are you familiar with the quality and outcome framework? Some of you might be. The quality and outcome framework is the bribery and corruption used on GPs to get them to deliver particular sorts of high-quality evidence-based interventions. So, for example, in diabetes, GPs will earn more the more patients they get having had retinopathy screening. the more patients who've had chiropody checks for nerve damage in their feet. And all the interventions that are described in the quality and outcome framework are nice, based on nice guidelines, and are considered to be best practice. So by implementing the quality and outcome framework within Broadmoor, we are able to demonstrate that we are providing high quality care. And we now report on our QOF outcome scores to the Trust Board. Because the Trust Board, besides being responsible for the mental health care of the patients at Broadmoor, they're also responsible for the physical health care. And they were getting no data previously to know how effective the physical health care was. Now they're getting the QOF data and can compare that to the national standards. So we needed an effective IT system, so we used one which is straight off the shelf, which is the EMIS. Very straightforward. There's lots of GP systems around. Rampton uses a different one, Ashworth uses a different one, but they all will calculate the QOF outcome scores. So there is a really important message that if you're involved in one of the medium or low secure units, you need to think about getting a primary care system in to allow you to evaluate the care that you're providing. And then we had a multidisciplinary team. We had dietitians, we had a chiropodist, we had a physiotherapist, and we had nurses. And we had a separate gym providing exercise and exercise therapy at a swimming pool. And what was happening, that the clinicians themselves were very good, very effective, very caring individuals, but there was no coordination. They weren't able to identify people that were high risk. And in today's environment where resources are really being constrained, that we are constantly having to look at how we can use our resources in the most effective way, we started identifying the patients who were at high cardiovascular risk, and then having a multidisciplinary team meeting that would focus just on those patients to look at how we can change and reduce the risks of the patients at highest cardiovascular risk by working together. So we had, as I say, the dietitian, the physiotherapist, the exercise and therapist group, as well as the nurses and myself, working out to ensure that the patients were on the most effective medication, that they were being prioritized by the gym to be taken there and use the swimming pool and use the exercise, so that those who were most likely to suffer a heart attack were getting the priority for interventions. And this was the algorithm that we used. You can see that we split our groups up into 3 groups, and we made sure that where patients were high risk, that they had all the medications that they needed. They had metformin, aspirin, ACE and statins, that the dietitians prioritized this group, so they worked one-to-one with those who are high risk. If they were lower risk, they looked either at group work or self-help. So there was a real prioritization of the work of the dietitians and in exercise as well, to make sure that we were identifying those at higher risk and using the resources in the most effective way. Metformin we are using not only for those with diabetes, but those who are very large, with very high BMI, because metformin increases insulin sensitivity and will help reduce people to lose weight and reduce their risk of diabetes, of developing diabetes. So it's a primary preventative measure. And there's some good papers both from the UK and the US. And the US ones are particularly around metformin in people with severe mental illness to reduce the chance of developing diabetes. The innovations that we looked at, one of the things that became very clear early on is that there are a group of patients where all the normal advice that I might offer in Mitcham worked in reverse. So if, for example, I said to you, sir, I'm really sorry, you've got diabetes, and if you stick to your diet, you'll live longer and you'll have, a wonderful life and you won't need to take any tablets. And in Mitcham, that usually worked quite well. But when you try it in Broadmoor, you get the reply, "Pucker that for a lark. Why would I want to live longer in Broadmoor?" So a lot of the sort of responses that we got, and a lot of the way that we try to offer what would be considered evidence-based best practice, worked in reverse. So of all of our 20% of patients with diabetes, none are managed by diet alone. They're all on medication. And that's unlike in the community where between a third and a half are managed by diet alone. So the issues are quite difficult. And we were struggling. We ended up with a small number of patients who, no matter what we did, that we thought we were offering the best way of changing behaviour, had absolutely no effect. And so we had this moment of epiphany. We need a psychologist. Where can we find a psychologist? Bugger me, we're in a bloody mental health hospital. We had loads of them trained in motivational interviewing. And we actually, the psychologists and the nurses who were trained were actually amazed to be asked to come and manage not a mental health problem, but to be managing a long-term condition problem. And so we've been starting to use motivational interviewing for patients who are most resistant to change. And that's been really quite successful. It's a unique set of circumstances, as you can imagine, but we've had really quite good success. The other bit that I wanted to talk to you about is bariatric surgery, which is gastric banding and gastric bypass. And the press about gastric banding is actually quite difficult because it's often linked to people who perceive themselves to be overweight and go to a plastic surgeon to get something done that they don't normally get to follow up. However, there's an increasing set of press about the benefits for people who are severely morbidly obese, who have gastric banding. And a study in the New England Journal of Medicine about 6 months ago showed that diabetes resolves in up to 75% of patients who have a Roux-en-Y gastrectomy, which is an absolutely extraordinary figure. That we're beginning to look at cures now for diabetes, and never before was that available. And if you have people who have a severe mental illness and a BMI of 35 or 40, which I suspect quite a lot of you do, and they're at risk of diabetes, and you can improve their health outcome and their perception of themselves by having a bariatric surgery, that is extraordinary. The trouble with all the research that's been done so far is that the research tends to exclude people with severe mental illness. Most research on clinical outcomes tends to ignore people or exclude people from the research study if they've got a severe mental illness, because they're hard to manage and all the rest of it. What we need is a research study looking particularly at people with severe mental illness who would benefit from bariatric surgery. And I think in the other stream, the dietitian and psychiatrist from Broadmoor are talking about a patient that we managed through the process of bariatric surgery and how how that was handled, because it was quite an interesting set of issues. So, in summary, schizophrenia and physical ill health really is a lethal combination. That smoking is only one factor that influences. Diabetes and obesity are just as significant. And that we need a planned and targeted approach using public health methodology, using a multidisciplinary team to address cardiovascular risk. Because good organisation and the multidisciplinary team really can have some really useful benefits. Thank you very much for your time.